Hello everyone, Ashley here. I'm presenting my project on megaloblastic anemia by alcoholism. So a little disclaimer before I start, since 1 in 10 Americans suffer from alcohol use disorder, it was found that over half of Americans increased their alcohol consumption during COVID-19 lockdowns, so 60% of Americans over the age of 12 suffer from alcohol use disorder. So those of you who know someone or have a friend of a friend, you know how hard it can be, especially when that person has a family that cares about them or they have changed their behaviors towards you and the world. Try to get help for them. I really wish there was a way to get people with a known problem to stop them from purchasing alcohol. So usually they scan your ID. I wish that there was a way that that person could tell that they've been coming here consistently every day, and be able to ban them from purchasing or something like that. But please don't give up and help that person or yourself to get help. Yeah. So first thing, I'm going to introduce megaloblastic anemia, then talk about the biochemical process in the liver, the chemistry diagnosis, hematological diagnosis, immunological effects, and the prognosis and treatment. So megaloblastic anemia is a blood disorder that occurs when red blood cells are larger than normal and there aren't enough of them. So as you can see in the picture on the right, we have oval macrocytes, which are larger than the red blood cells, the normal red blood cells, and hypersegmented neutrophils, which result from the delayed maturation of the erythroblasts. So to study this condition, we can do a complete blood cell count, which measures and tests the number of and function of the red blood cells, as well as the white blood cells and platelets. We can do a peripheral blood smear to test and examine the blood sample under a microscope to see the appearance of the blood cells, take a reticulocyte count to measure the number of immature red blood cells in the bone marrow, and also do some chemistry tests that involve finding the level in the blood of vitamin B12, methylmalonic acid, and homocysteine levels. So this shows the biochemical process of the liver that's affected by liver cirrhosis, which leads to megaloblastic anemia. There's 5 stages in liver damage. You start off with a healthy liver, it becomes a fatty liver, then liver fibrosis, then what we're going to be studying is liver cirrhosis, and then if it continues further, it could turn into a hepatocellular carcinoma. So chronic alcohol consumption impairs the absorption of vital nutrients, which include vitamin B12 and folate. So looking at the chart, liver cirrhosis disrupts bile production, which impairs the bile flow and reduces the vitamin absorption. So that vitamin B12 folate malabsorption deficiency are cofactors for DNA synthesis. So without B12 and folate cofactors, there's an impaired DNA synthesis and ineffective erythropoiesis, resulting in megaloblastic anemia. It is found that the majority of alcoholics have abnormalities in their red cell population, with greater than 40% having megaloblastic anemia. So here's the process of alcohol through the liver. First starts as alcohol, and then alcohol dehydrogenase, an enzyme in the liver, breaks it down to acetaldehyde, and then acetaldehyde dehydrogenase then breaks it down to acetate, and then further oxidation occurs and results in water and CO2, or carrying the acetate through the citric acid cycle. In order to diagnose megaloblastic anemia, they used to find that a majority of the cases for megaloblastic anemia were folic acid deficiency, but now that deficiency is not as common as B12. So in the case study, we have a 52-year-old male who is a construction worker complaining of fatigue, weakness, numbness in his hands and feet. He also presents with a complaint of increasing fatigue over the past 3 months, and he notes intermittent numbness and tingling in his hands and feet and occasional shortness of breath on exertion. He denies chest pain, palpitations, or any recent illness. The patient mentioned that he unintentionally lost 10 pounds in the past 2 months. So we know that the patient has been a chronic alcohol user for the past 20 years, consuming 6 to 8 cans of beer daily. He has a history of chronic gastritis, and on presentation, his skin was paler and jaundiced with yellowing of his eyes. He's mildly tachycardic, and his liver was palpable 2 centimeters below his ribs. He also presented with atrophic glossitis, which is a swollen tongue and possibly caused by nutritional deficiency. His complete blood cell count showed hemoglobin 8.5, which is really low. His MCV was elevated, which you can see in macrocytic anemia. His reticulocyte count was low. Platelets were mildly low. White blood cell count was low. In the peripheral blood smear, there was a presence of macrocytes and hypersegmented neutrophils, which is suggestive of megaloblastic changes, and his serum B12 was low. Serum folate was low, and some liver function tests that were performed were AST, which is elevated, ALT elevated, and GGT, gamma glutamyl transferase, which was markedly elevated, which is indicative of alcohol-induced liver injury, and his bilirubin was elevated. Serum homocysteine elevated, serum methylmalonic acid elevated, and his iron studies were in normal limits to rule out iron deficiency anemia. So in the chemistry diagnosis, they use the Madre's discriminant function, Glasgow score, model of end-stage liver disease score, the MELD score, to guide in the treatment and severity of the liver. And these scoring systems used bilirubin, INR, creatinine, age, white cell counts, blood urine nitrogen, and albumin levels to stage and guide in treatment. And as we know, alcohol interferes with the folate and vitamin B12, which reduces their metabolism in the liver. And we also see an elevated gamma glutamyl transferase, which is associated with alcoholism and liver damage. The total protein in albumin is decreased in liver disease. Methylmalonic acid are increased in B12 deficiency only. So we've seen with the patient that they have an increased methylmalonic acid, so there is probably due to B12 deficiency, but they also have an increased concentration of total plasma homocysteine, so they also have folate deficiency. And so serum folate and RBC folate are also measured, and those are usually low. We also look at the protein electrophoresis to identify if the patient is in active cirrhosis. They'll have a beta-gamma bridge, and a elevated albumin. But it will still be lower than normal. as you can see by the dotted lines. So some things you have to remember for liver failure: you would always have a decreased RBC, decreased hemoglobin, hematocrit that's decreased. Mean corpuscular volume is going to be increased because it is the measure of the size of the cells. Mean corpuscular hemoglobin is increased, red cell distribution is increased, and the reticulocyte count is decreased. Hematological diagnosis shows pancytopenia, folate deficiency, which reduces the production of red blood cells, macrocytosis of red cells, ineffective thrombopoiesis, and ineffective granulopoiesis, interfering with the absorption, storage, and release of those vitamins. Serum iron levels increase during drinking episodes but return to normal after cessation. So we'll see ring sideroblasts in alcohol abusers due to the fact that there's iron deposits which form rings around the nucleus of the cell. Symptoms: alcohol can make you feel good, give you confidence, but it also causes impaired vision, slurred speech, vomiting if you drink too much, fatigue, hangover, hepatosplenomegaly, which is enlarged spleen and liver. And then clinically, liver failure leads to a decreased vitamin absorption, fatigue, nausea, unintended weight loss, jaundice, bleeding from the GI tract, and intense itching. Swelling in the legs and abdomen is also seen, and it's common. It's called ascites, in which the abdomen is swollen. And there's also clinical findings of hyperpigmentation of knuckles and terminal phalanges in Asian communities, enlargement of liver and spleen in up to 30 to 40% of cases, which mimics acute leukemia. Petechial and other hemorrhagic manifestations have been reported in 25% of cases. Presence of bleeding with severe anemia makes them clinically indistinguishable from aplastic anemia as well. So for the prognosis and treatment, patients with megaloblastic anemia showing the presence of those ring sideroblasts should be supplemented with peroxidine in addition to vitamin B12 and folic acid. Some common treatments or supplements given is 1 milligram of folic acid daily, and also a B12 shot, which is 1,000 micrograms intramuscularly, that the patient is given weekly for 4 weeks, followed by monthly injections. And the patient is also given dietary advice for the intake and emphasis on folate and B12 rich foods like leafy greens, fortified cereals, meats, eggs, and the patient is then given after 1 month a CBC, folate, and B12 recheck and liver function tests, and monitored for neurological symptoms. So the way to treat chronic alcoholism is abstaining from alcohol to treat that liver cirrhosis. There's a 5-year survival rate of 60% in those who abstain from alcohol and 30% in those who continue to drink. Thank you all for your attention, and I hope you enjoy your weekend and stay safe.